held together by a number of ligamentous structures, but most importantly is that interosseous or the syndesmotic ligament. Now, I don't know if you have these candies in the Caribbean, but in North America, we love these. They're called Lifesavers. They're hard candies. So and they have a hole in the middle, like a lifesaver, like, a boat lifesaver. I tell my residents, try to break a lifesaver in one spot. You can do it. It's not easy. You almost invariably break it in two spots. So bony rings are very similar. So if you think about the tibia and fibula, it's a bony ring, albeit a flat ring. And the radius and ulna are a flat ring as well, but it's a ring. The mandible is a ring. The pelvis is a ring. If you break it in one spot, you got to find, or injure it in one spot, you got to find the second ring break. So we've disrupted the medial aspects of the deltoid. Where the heck is the other ring break? And so this is where you have to examine the entire ring structure. So can you see the fracture? Laterally, it's this tiny little thing. And then over here, you go, oh, that's nothing. But you've disrupted the deltoid, the foot's everted on a fixed tib fib, and it's rotated. The talus has hit the fibula. Either you get a Danis-Weber fracture, so it's usually a B or a C, but it's held intact. The tibia or the talus hit it. It split that syndesmotic ligament all the way up, and it's popped out here. So this tib and fib are completely unstable. So every time you walk, it's pulling apart. And, this classic eponym is a Maisonneuve fracture. The key is you've got to examine that entire ring. And if you did a compression test where you were squeezing the proximal tib fib, you probably would have found that first day he's sore up there, really sore in the ankle, but he's ignoring this minor pain in the proximal, leg. But if you squeeze it, it hurts, or you get the entire ring X-ray just to be sure you're not missing something. Another one, classic. How many of you've had residents or junior registrars or even senior registrars, telling consultants, oh, it's just a wrist sprain? Yeah, it probably is, but you've got to think about the mechanism. If you don't see anything, look again, especially if they're having symptoms. If they're really sore and it's swollen, look again. You may need different radiographs or different modalities of imaging. So just, you guys are all experts. The normal wrist, whatever your mnemonic is to remember the 8 carpal bones. So the AP, the nice Galula's arc should be nice and smooth, beautiful. The lunate should be looks like a trapezoid, should be square shaped. And the intercarpal distances should be symmetric. You can remember your number 3 millimeters, but they've got to be symmetric. And the third metacarpal through the capitate into Lister's tubercle should form a beautifully nice straight line. And laterally, you've got to look for the 3 C's, the radius, the lunate, and the capitate. They've got to line up. All right. So, it's just a sprained wrist. But is sore in the anatomic snuff box? Sore with ulnar deviation of the hand? Painful when you abduct the thumb and actually load it? You go, man, I wonder. So plain x-rays, but we'll ask for a scaphoid views, which involve, ulnar deviation, which basically pulls the scaphoid into looking like a boat. The proper Greek term is navicular. So it does sort of look like a boat. And a little bit of a scaphoid fat pad, and you can clearly see a fracture, but it would be easily missed without the proper views. So look again. Another one. This is a classic one. We're, working with, senior residents and I guess, junior faculty. Everyone can see the green stick fracture in this 15-year-old, and it's easy to fix. But did you see the concomitant scaphoid fractures through the waist? It's so big and so displaced. It looks like, it's a bone. There's 2 bones there. Easy to miss. In fact, I wish I should have had the reduction of the distal radius fracture, the green stick is perfect. And so it's in a beautiful position, but that scaphoid, on them pulling it, is actually even more displaced. So if it's a wrist injury or it's a sprained wrist, it's something, it could be something to proven otherwise. Another, so swollen wrist, a gentleman, falling out of a tree. We joke, they were raking leaves, but he fell out of a tree. He was obviously drunk, doing something silly, fell out of, injuring his right hand. So there's the first Gilula's arc, is beautiful. Second one, it's not normal. It's not smooth. The wide space compared to the other sides, these are abnormal. Something's wrong. And then when the lateral, easy to miss. There's the radius. There's the lunate. There's the capitate. The 3 C's don't line up. Swollen arm. These are shockingly easy to miss. And in the US, they're very high medical legal. It's a wrist sprain. You send them home and they don't get any better. In fact, they get worse. And then you end up with arthritis and problems with that wrist, especially if it's his dominant hand. So that's a classic, perilunate dislocation. Easy to miss. You got to look. Another wrist swollen. And so our EMS crews have put on just a splint to hold it in position, which is a kind thing to do, keep it from moving. And so here we go. So if you look at that arc, the proximal arc is fine. There's overlap there. That's an abnormal Gilula's arc. And then look at the shape. This should be trapezoidal in shape, but it's actually more like the sector shape. We call it a Hershey kiss. I don't know if you have them in the Caribbean, but around Christmas time, we get these chocolate filled goodness things, and it looks like a Hershey kiss. So we call it the Hershey kiss sign. So here's another picture of our other lateral, just off the Hershey kiss. Something's wrong. That lunate's not normal. And there's also a concomitant scaphoid fracture, which there's a lot of force in there. Something's going wrong. And then the lateral. So once again, easy radius. Oh, there's the tip teacup sign, the lunate, and there's the capitate. So push, and the median nerves right here. And I was really happy that was on an exam question, and I was impressed at how quickly the candidates nailed it. Fabulous. So my last management point, and once again, I don't want to give anybody a DVT, been sitting around, is I really want, especially our graduates, our DM1s and DM2s, to promise me that you'll take care of yourself. I've been doing this an awful long time. I'm a trauma leader, trauma team leader, at a major trauma hospital for years. You will see and deal with things that are truly horrific and are potentially, soul destroying. I was very impressed at some of the stations that were talking about delivering bad news, and we all get triggered a bit. I remember my first time as a senior registrar having to really deliver bad news. A family was involved in a van, was involved in a high-speed motor vehicle collision. Their van hit a 5-ton fully loaded gravel truck and basically vaporized most of the family. The husband, the wife's mother in the front seat died on impact. In the 2 captain chairs, a 9-year-old and a 7-year-old were killed. And in the back seat, a mom, a 5-year-old was killed. And then she was breastfeeding because the baby was fussing. A 9-month-old took out and then was wrecked. And so this poor mother survived because she was in the very back part of the vehicle. It was a head-on collision with a femur fracture. And her baby had head injuries not compatible with life. So we were in the process of having to withdraw care of her baby. Her mother, her husband, and her other 3 children have died. And I'm having to break this horrible news to this lady. And it's been 25 years, and I can still hear her screams. I can still, that animal noise of hers, and I can still think, oh my God, I didn't sign up for this. And one of my mentors, said, you just didn't know you signed up for it. So it's critically important, if you want to survive being in an emergency department, is that you keep a healthy out of hospital lifestyle, that you take care of yourself. these are images that, you know, you will see. Top left is we bring our family members in for pediatric resuscitations. And you never want to be the last member of the resuscitation team going in, because your job then is to deal with family. And they're wearing lead, so we put lead on everybody so that they stay in, especially a parent. So this is a mother, and we have it bright pink. It says relatives. So you come running in and you know, oh God, there's a mother, or there's a family, as we're doing CPR on their children, doing resuscitation on their child. And so everybody is professional, calm. There's, you know, we keep our language, you know, very, you know, sensitive to who's in the room. And the last person in, your job is to explain to the parent or the mother, the father, exactly what everything's going on. It's the hardest job in the room. The poor mother in the middle, that's a Sandy Hook. So when they had those kindergartners and grade oneers that were murdered in at Sandy Hook, this is a picture from I think it was the Washington Post, of one of the mothers arriving at the hospital and finding out that her 5-year-old's dead. The one on the right has been going around social media. It's an emergency physician in the United States. They've had a young teenage girl, 17, 18, whatever, who died from an anaphylactic reaction and needed a moment. So he's gone outside and is dealing with it. And a paramedic took a picture of this. You know, that we've all, anybody that's done this for a long time, we've been there. You know, haven't maybe gone outside, but we've been in those horribly dark places. And the bottom one is RCMP. So this is actually on one of our flight teams, took a picture of this. We are on scene on a highway. We're basically taking a road traffic collision. There have been 4 kids, they're teenagers, killed at this scene. One is critical, and we're loading. And it's a rural area. And this is a farmer's, this is a father who's come across the crash, recognized that wrecked vehicle. That was his kids. And his child's dead. And these poor police officers are trying to keep him from, this child is, you know, he's, you know, as you get older, 17, 18-year-olds are children. This 17-year-old is destroyed. Like, his body is destroyed, and they're trying to keep him from that. And so we will see things, we will experiencing things that most people can't understand. So you need to take care of yourself. This is my final, you know, invocation to you, is for every major resuscitation, trauma or otherwise, you know, ask yourself what went wrong, what could have been improved, what went well. Listen and share with each other. We're teammates. Be humble. Take and give feedback with humility. Look for ways to improve. It's always about patient care. Wave that flag, patient care. How as a team can we get better? If you don't have debriefings, because, you know, we're supermen and women, we don't need debriefings, and that's wrong. If you have debriefings, attend them. If you don't, I suggest in your career, start them. We're a team. We need to reach out when you see someone on our team is struggling, and you need to ask for help if you need it. Asking for help is not weakness, it's actually strength. You need the insight to realize, I'm having trouble with this. And everybody, I've been doing this a long time, and occasionally something gets through the armor and you need to talk to somebody. You need secret keepers that are hospital and outside. So if it's your mom, it's your partner, if it's your sister, your brother, if it's a priest, if it's a, you know, a minister or whomever, you need to be able to unburden and talk freely. If it's a mentor in hospital, talk to them. And I'm just going to leave you with, this is a gentleman's right leg. That's his medial malleolus. So try to figure the orientation out. That we had to rotate that 360 degrees in a clockwise rotation. He came in, this is when a smart car, I don't know in the Caribbean if you use these little, you know, smart cars. This is when a smart car meets a great big 3/4 ton truck. And the reason I'm showing this, other than it's, you know, it's an amazing X-ray, a picture, is that patients are absolutely amazing. So this poor man with a femur fracture and other injuries is, the sociologists refer to it as cognitive, or the psychologists, cognitive reframing. He's in pain, but he's probably one of the funniest men I've ever met. He was joking, he's trying the worst day. He's trying to make it better. And he was saying, oh, because he could see his foot. He said, God, my feet stink. And we're trying not to laugh. And he says, Doc, I'm trying to make things better for you, save the system money. You can take a picture of my chest and my ankle all at the same time. As now we're going to sedate him to straighten this leg out. So patients and humans will surprise you. They're having their worst day, and yet they give you the grace sometimes to, be proud of the fact that we are part of the same race, the same species. Before I finish, any questions, please?
Okay, Prof. Not seeing any questions in this chat. Just alerting the persons, if you're not aware, some of your videos are open. You might want to check. There is no question currently on the YouTube platform. I have a question.
Yes, ma'am.
The gentleman with the shaved off nose. What happened? What eventually happened?
So he had just minor head injuries, other than this horrific nose. I phoned. I was on trauma team. I called our facial surgeons, our plastic surgeons, and a junior resident said, "Oh, we're into laceration service." And I thought, if you got a, and I said, "Oh, really?" So I hung up. I woke his staff up. It was about 7 o'clock in the morning, and it was just after Halloween, which is a big thing in North America. I don't care, but I don't really care. But I woke up the plastic surgeon at home, and I said, "You need to come in." And I sent on, we have an ability to send on secure emails on our work platform. I sent these pictures. And he
Sorry,
said,
Prof, my
yes.
apologies. There is a Joanne Pollock. Please close your video.
Okay.
Thank you.
All right. And he said, this had better be a Halloween gag. I said, no. So they came in, and finished resuscitating all the images. We came out of the room, and I had 2 staff plastic surgeons with their loupes on looking at this nose. And I asked them, what are you doing? And he said, we're trying to find a vein that we can supercharge to give arterial supply back to this. And I said, what if you can't? And he said, well, then we have to make a nose, which isn't easy. So 14 hours later, they were able to 2 small veins attached to, his already facial and nasal arteries, put it back on. And then I wish I had video, because I went to the OR. It took 14, 15 hours, and they had leeches on his nose just to get the venous congestion out. And they were able to save his nose. He had on his left side, the infraorbital nerve was damaged. They tried to put it on. So his face was like this for months, but he wore glasses and you really couldn't see much of the scar. So they were able to save his nose.
Impressive, sir. Thank you so much. All right. There is a question. Oh, somebody's disturbed. They said, did you say leeches?
Yes. And so they use medicinal reducible leeches. So they're sterile, and they've been used. And basically on reimplantation, the arterial supply is there, but it takes a while for the venous supply to coalesce and develop. And so you can get this quite a congested limb that can cause back pressure. So they make little nicks and put these leeches on, and they suck the blood out. Yeah. It's disgusting, but it works.
It does sound disturbing. So we have our first question. Are most of your trauma during the winter months?
Good question. No. And the picture I have up are the 4 seasons in my part of the world. So summer, spring, winter, and then fall. No, our busiest trauma months are May to about July. So the weather is finally nice. People have been sick of being hibernating at home in wintertime, and they're out doing risk-taking behavior. So our busiest trauma months are, May long weekend kind of, and then to the end of summer. That's a good question. There are different types of injuries, road traffic collisions, but sports related to winter, so hockey, ski jumping, skiing, things like that, you will see different types of injuries.
Okay, thank you. Another question was, do you have leeches at your hospital?
We actually have them upstairs. So we're the major transplant hospital for Western Canada, including limbs and other things. And so one of the things that we might see a lot of is frostbite and hypothermia injuries. And what we will do is, you've got these big congested, usually toes or fingers, and we'll use the leeches. So we have them upstairs, and the plastic surgery, they grow them, and they're single use only. Once they finished feasting on your finger or your nose, they are unfortunately destroyed, but they're kept in a sterile environment, so they don't pass on any bacteria or viruses, but we do have them.
Okay. I have another question. I heard you say earlier that you see 50,000 kids per year and then about 72,000 adults per year. So you guys have quite a lot of kids.
Yes.
What is the biggest presenting complaint or the commonest presenting complaint why there's so many kids coming in?
Well, so that's a great question. So in Canada, there's about 40 million people. We have 11 pediatric hospitals. And so in my city of just over 1 million people, most of the general hospitals will have emergency departments. We'll still see kids, but people sub-select. Once you develop a pediatric hospital, I'm sure in Trinidad, in Port of Spain, people will bypass other hospitals to come to the Eric Williams Center, and I'm not sure if Jamaica has a pediatric hospital itself, but they will come. People sub-select. So as you know, since 2000 we opened our hospital, the number of pediatric presentations at the other sites gets less and less and less every year, and so that's why they'll come to see us. And we have a publicly funded healthcare system, so it's free, and so people just show up. And so they can use the emergency department as their primary care physician stuff but that's usually what happens.
Okay, cool. So yes, we do have a children's hospital.
Okay.
That's a Bustamante Hospital for Children here in Kingston. Yes. And then in the Western region, one is currently being built, so we'll have two soon. Another question that is here is, up to what age is considered pediatric at that hospital? Yeah,
so we 18 less 1 day. So all the 17-year-olds, 17 and 364 days we see.
Okay, so not too different from you. Well, short by about 2 years. So 16 is when you're an adult.
Yeah. Well, we used to about 5 years ago see only 16 and less. But they've added to 17. And I for any of my colleagues that do pediatrics as well, that 17-year-old age group, that's where we start seeing lots of drugs, lots of mental health with addictions issues, lots of interpersonal violence. And so you have a 17-year-old and 11-month who's intoxicated, screaming, making our entire ruckus, terrorizing 2 and 3-year-olds. So personally, I would like to see 16 or less, but I don't make those decisions. If we joke, if you've had more children than the staff in the peds hospital, if you have more facial hair than the pediatric people working, you probably aren't a kid.
Okay, thanks. Another question just posted. They're asking if you had worked in any other country aside from Canada, and how was it different from your hospital, ER or ED?
That's a great question. So I did in Canada, you get you need a bachelor's degree, so 4 years, and then you go into med school 4 years, and then emergency medicine is a 5-year residency, the Royal College, and then in that you can do a year of subspecialty. So I spent a year in Baltimore at the Cowley shock trauma, and then when I finished, I realized I love trauma, but kids were my thing. So I would spend time in DC, the National Children's, and at Colorado Children's, and so I've worked in the United States, and essentially about 2.5, 3 years. I've also worked in Taiwan. I've helped them set up their emergency medicine program in Taiwan. So those are the two places I've worked. The US, like my mom is an American. They emigrated from, I'm Czech, from the Czech Republic. And so my father came to Canada, my mother, Czech, went to the US, and her family moved to Canada, and that's where my parents met here. I didn't think I was so much of a socialist. If you say socialist in the US, it's like I'm swearing at you, but really, you just means you're your brother's keeper. I didn't think I was so much of a socialist till I went to the United States. And so it's a very different system. The thought of making money on a sick person is foreign to Canadians. The idea that people can't or won't attend to their children or their medical needs because they can't afford it is foreign to Canadians, and it's an anathema to what we believe. And so I found it disconcerting. I found it very strange to work in the United States. Trying to order a CT scan on a patient, I had to, phone their HMO. So some pimply-faced kid in another state would give me permission, or I had to transfer my patient to another facility to get, their healthcare service that would pay for that. So I found it quite different. And so I know that in the Caribbean, you have a dual system. There's public and private. And so going through the case series, the case books for the DM2s, reading that, it reminded me of being, in some ways, being back in the United States.
Okay.
Does that make sense?
Yeah, yes, it does. I hope it answered the question the person was asking. Another question that was there: do you have any direct advice to the new graduates who just completed their DM?
Enjoy it, and then get in. There's a 10,000 hour rule for anything, including a new physician, a new specialist, a consultant, is that you've got to spend 10,000 hours learning the art. You've got the science, you can continue to learn, but you've got to put time in to learn the art of it. There's more than one way to do things. Be open-minded to learning new things. Just because you finish doesn't mean you're done. You need to be serious about your continuing medical education and always be curious, asking questions. How can you get better? And I think you need to also realize that your mentors and your teachers are wonderful teachers. They're amazing. But your biggest teachers are your patients. Be humble, learn from them. And don't forget that we're there to serve them. And as a physician, as a Canadian, like this is our raison d'etre. We don't have a perfect system by any stretch of the imagination, but I'm there to serve my community and be a role model for your community. Listen to your patients, learn from them, be humble. You can learn something from anyone, even if it is, I will never do that to another human being, the positive or the negative learning experience, but you can learn from anybody. Be humble, take your job seriously, take your craft seriously. We have an amazing job. Nothing wrong with selling shoes, nothing wrong with being a farmer. I come from being a farmer. My parents were on the farm, but we have a higher call. We have a calling. So really take it seriously. But my last point would be, promise me, you're going to spend the rest of your life in the pursuit of excellence. Be curious, to learn, to change, to adapt in medicine. And that's laudable, but promise me you'll have fun. It's the best job I've ever had. There's not a day goes by that I don't laugh. I don't look at something and go, that was amazing. I can't believe they pay me to do this. So enjoy the ride, because in a blink of an eye, you look and go, oh my, I got more behind me than I have in front of me. I maybe got another, as a 52-year-old, almost 53, I don't have that much time left. I wish I could start over. In a blink of an eye, it's gone. So enjoy the ride.
Thank you so much. And one final question before we close. How well developed is pre-hospital emergency medicine where you are?
Very, very. We're very lucky. We have multiple levels of it. So we have what's called primary care paramedics, which are basically, they can start intravenous's, do medications, run AEDs, transport. Then we have advanced care paramedics, which, they can intubate. They can, they use a life pack 15. So they interrogate. We will thrombolize in the field. So we will give, because we're so rural, we'll give thrombolytics for MIs in the field. We actually thrombolize. We have a stroke ambulance that actually goes and meets people. It's this great big 3-ton truck, an ambulance with a small CT scanner in the back. We scan the head and they'll thrombolize strokes in the field. Then we have critical care, advanced care paramedics that are our flight medics. So they'll actually go out in the planes and in the helicopters. And then we have community paramedics, which are even more trained, and they work with nurses, and they actually go to nursing homes and seniors apartments and other places, and they'll put stitches, suture patients up. They'll do reductions, minor reductions, and they'll manage the elderly in place to keep them from coming into the hospital. Our flight medics they do ultrasound. They can put central lines in. So it's very advanced.
That is quite impressive. Wow. All right. Thank you so much, Prof. I will go ahead and invite Dr. Daniela Malcolm to give a vote of thanks.
Hi, good evening all. And I'm sure you agree with me that this has been a very insightful and delightful grand rounds, right? Professor Shevchik actually left us wanting more. A colleague of mine was saying, it's finished already? Right, it was awesome. So special thanks to you, Professor, for coming out and sharing with us all your pearls, well, not all, but some of your pearls that you've picked up in the emergency room. And we do hope to hear from you again, right? Thank you to our consultants, Dr. Hudson, Dr. Jean Williams-Johnson, Dr. Edwards, and all the other consultants who were behind the scenes helping us to prepare this grand rounds for this evening. Thank you to my colleagues, Dr. Paula Williams for moderating, Dr. Hibbert for doing the prayer, Dr. Campbell Patterson for delivering the introduction of the speaker. So thank you all. And of course, Dr. Morris and Dr. Hall Okori, who also helped to prepare this grand rounds. And most certainly, thank you to our audience. Thank you for joining with us this evening and participating in this evening's grand rounds. All right, I know it has been great. So thank you all and do take care.
All right. Thank you, everybody.
Thank you so much, Dr. Malcolm. Have a pleasant evening, everybody. Thank you so much for joining us for another great ward rounds. Everybody walk good, Prof. It was wonderful having you.
Walk good.
Yes, walk good.
I love it. Yeah. And thank you for not speaking too fast. Bless your hearts.
No problem at all. All right. Thank you, guys. Have a good evening. Bye-bye.
Yeah, thank you all. Okay. Thank you.
Thank you, Jean. Bless your heart. Thank you so much, everybody.
Okay, bye.
Take care, Prof.
Good. Bye.
Bye-bye.